As healthcare moves away from traditional fee-for-service models, providers need a strategy to stay competitive. That's where Strategic Healthcare Partners comes in. We offer expert consulting and ongoing management oversight for providers looking to form an accountable care organization. From financial feasibility analysis to helping you choose the right ACO in a crowded market, SHP provides the clarity you need to make informed decisions and transition to value-based care. Learn more at shpllc.com. This is Jason Crosby of Strategic Healthcare Partners, and your host for today's episode. We are joined by Dean Rottinghaus of the Diabetes Management Clinic at Jenkins County Medical Center. We came across Dean and his team while working with Jenkins and the possible expansion of their services in the South Georgia market. It was during this time that we in the hospital administration found the clinic very community friendly and another mechanism in which they, the provider, can interact or engage with the patients in their market they previously would not have. So with that, let's jump right into the conversation with Dean. For our audience sake, some background on how we're familiar with Dean and his team. We have collectively shared a client, Jenkins County Medical Center, as I mentioned before. We came across Dean and his team. Jenkins, a critical access hospital client in the South Georgia market, where the diabetes clinic is up and going as of last year. Community's happy, administration happy, and so we wanted to have Dean on to sort of expand on diabetes treatment. So with that, let's just jump right on in. Let's start with the sort of the problem side of this equation, the education side, and tell us what are some of the statistics pertaining to the epidemic of type 2 diabetes, hypertension, and kidney disease.
Well, yeah, absolutely. Jason there, and I've written them down because the numbers are they're staggering. So I'm going to talk specifically about the prevalence of type 2 diabetes. Let's kind of just run through some of these stats. So the prevalence of type 2 has increased from 2.5% of the U.S. population in 1990 to 10.5% of the U.S. population in 2018. So, that's obviously 4 or 5 years ago already. So in almost 30 years, the prevalence, the incidence of type 2 diabetes, we're only talking about type 2 diabetes, has increased by 320%, which is, like I said, just absolutely staggering. Additionally, and this doesn't, like I said, doesn't even include type 1 diabetes, which is, a different animal altogether, but it doesn't include the 88 million people who are pre-diabetic. Diabetes is measured by what is called an A1C. So A1C levels above 6.5 are considered diabetic. And so pre-diabetic are these 88 million people that I'm talking about have A1C levels below 6.5. So they're right there on the verge of adding to that percentage. And so kind of, and cut me off, Jason, if you need to interject there, but I'm going to go over some more stats because it doesn't get any better for what we're dealing with here in the U.S. Type 2 diabetes is expected to increase to 13.9% of the U.S. population by 2030. So what I said is in 2017 or 18, we were at 10.5. So we're looking at another 3.4% increase by 2030 to 39.7 million people. So let me then, again, kind of setting the table for what we're talking about here. Let's talk about some of the money or what this cost, healthcare costs as it pertains to these diabetes. 2017, it generally cost about $400 billion as part of the U.S. economy, which is $1 out of every $4 that's spent on in the U.S. healthcare costs is spent on caring for people with diabetes, type 2 diabetes. By 2030, that's expected to be over $494 billion as far as a burden to the U.S. healthcare economy. So we're dealing with an endemic, and it's not getting any better.
Wow. Staggering numbers, to say the
Yeah,
least.
it's unbelievable.
Keep going down the education trail here. What are some of the root causes that we're talking about?
Well, this obviously doesn't happen overnight when we're talking about type 2 diabetes. Type 2 diabetes, a lot of lifestyle issues, and that's why we've kind of addressed it in a population where we are right now. We're trying to, generally in underserved populations, you're talking about incidences of in African American people, it's higher in African American people and Indian people, Native American people, I should say. There's a higher incidence in those populations. It's a higher incidence in areas where nutrition, where food supply is, you've got a lot of fast food restaurants. You got, they don't eat as well, and so it's in poorer populations. Generally, the incidence of type 2 diabetes is higher. So let's talk. That was kind of a roundabout way of going into what your original question was. What are the root causes? The root causes of diabetes, the type 2 diabetes, is insulin resistance. So insulin is used, it's secreted by the pancreas, by our bodies. And normally, it's secreted when we eat something, our blood sugar levels rise. And so the pancreas secretes insulin in response to that. And normally that insulin, cells respond to the insulin, and they take up that food, which is broken down. They take it up as glucose for energy. And what happens over a period of time, and we're talking about lifestyle changes, we're talking about lack of exercise, we're talking about habits that people develop over time, and aging. The pancreas does not, the cells actually don't respond to that insulin. They become insulin resistant. So when that food is eaten and broken down, the cells down regulate. It's called down regulate. They actually resist the insulin. They don't take up the glucose. They don't take up that food for energy, and it gets deposited into our cells, into our bodies as fat, as just lots of complications as a result of that. So that's really how that process works. That's the root cause of type 2 diabetes. It's the root cause of what that leads to is also hypertension. Our bodies, it gets deposited in our bodies as like I said, fat, and so then the heart has to work harder to get to maintain all of this, and so lots of comorbidities associated with that.
What are some of the others that we're talking about that are associated with the resistance of insulin? You mentioned hypertension and such. What are some others that maybe our audience should be aware of?
Yeah, I mean, a lot of them. I mean, we're aware of it, but people are aware of these comorbidities, if you will, but they don't generally relate them back to this insulin resistance and the diabetes itself. So what I mentioned it briefly: hypertension, high blood pressure, this inflammatory response. The body doesn't utilize the glucose for energy anymore. It gets deposited, and then we have, like I said, hypertension, high blood pressure. Weight gain was one of them I mentioned. Depression, lethargy. I mean, you start going down this whole path of body's not functioning properly anymore, and some of these side effects that occur, the comorbidities. A big one is kidney function, and we actually see this a lot in our clinic. The increased weight, the kidneys don't function as well, so GFR goes down, which is glomerular filtration rates. Our kidneys don't function as well because it takes more to excrete that out of the body. So our GFR goes down. Neuropathies, one of the big things with diabetics, and you've heard of diabetic neuropathies. That's where the nerves, the peripheral nerves, the nerves that the generally the feet they start to die actually, because they're not getting that energy anymore. And so then the patients or the people start to feel numbness and tingling in their feet and legs. That's neuropathy. Eye problems. You've heard of diabetic neuropathy. Our audience has heard of diabetic neuropathy, macular degeneration. These are some of the side effects of this insulin resistance, where the body just doesn't use that glucose for food anymore. And probably a big one, and this term hasn't been coined in the mainstream media, if you will, but it's type 3 diabetes, and type 3 diabetes is actually recognized as Alzheimer's and some of these metabolic disorders that dementia that occur over a long period of time when the patient or the person has not this accumulation of this inflammatory response in the body. Those are some of the, obviously huge burden to our healthcare system, but that's what we're talking about.
All right, let's transition to a lot of what you're doing today while you're at Jenkins, right? We've talked a lot about the education, causes. Now let's look at some of the solutions and treatments. What are some of the current treatments for metabolic disorders, whether it's type 2 diabetes, hypertension, et cetera?
Yeah, current treatments, turn on your TV any time and you're going to see, big pharma ads for diabetes medications. And so right now, the current treatment for diabetes, type 2 diabetes, let's just kind of focus on type 2 diabetes and pre-diabetes, but the current treatment is medication. And the medication, this is where where big pharma really leads this, but it's treating the symptoms. So you're really kind of treating the symptoms of the actual diabetes, type 2 diabetes. And what we've done is we've taken a little bit different approach, actually a drastically different approach, and we're actually focusing on treating the cause of this insulin resistance instead of really trying to maintain the patient. We're approaching it from a different way, and we're treating the insulin resistance. So that's kind of the program that we have here at Jenkins County Medical Center. Instead of, we want to minimize the insulin resistance, and we do that in a number of ways. I can go into that if you'd like, or I didn't know if you had another question for me there.
Let's maybe speak to some of the trends and what you're seeing today. So you got an active population. What are some of the current today treatments? Maybe go a little bit more detail on what you were saying there that either generally do not address or get focused on.
Well, so I mentioned it early on, Jason, and it's that lifestyle changes. These patients or these people generally with the lethargy, or they don't exercise as much. So a lot of those things we address that, weight management, smoking cessation, and things like that, where the patient or the person actually has to change how they are living their daily lives, because we talked about the burden on the healthcare system and emergency room visits. I mean, we see that all the time here at Jenkins County Medical Center, where patients are coming into the emergency room, the ED, for hypertension and high blood pressure and glucose. Their blood glucose is out of control. So we want to address that on the front end, and we do it. I mean, the crux of our treatment is actually infusion therapy. We do insulin infusion. I know you and I haven't really talked about that, but that we do insulin infusion. The patient actually comes into our clinic and they sit, and we do short little boluses of short little microbursts of insulin, depending on their A1C levels, depending on their blood sugar levels. They sit in a chair and in a lounge chair, if you will, in a lounger, and it takes about 2 hours. And what we do is we mimic, going back to what I said early on, the pancreas is what secretes insulin in response to a meal being eaten. So once that whole process breaks down, what we're doing here is the insulin infusion. We go back in and we actually jumpstart the cells we upregulate them. I mentioned downregulate because over a period of time those cells become resistant to the insulin. We want to kind of shock them into upregulation, where they now accept the insulin and they open back up and they accept the glucose for energy, and then the pancreas starts to operate again. It's a process. The daily life of somebody who has type 2 diabetes, they didn't get that way overnight. So this doesn't go away overnight. It takes a few weeks to really jolt that whole process.
Let's talk about that as well. What are you seeing trend wise? You mentioned some great statistics right off the bat. related to that, what are you seeing nationally or globally in terms of on the cause side of the disease that's maybe not addressed? It sounds like there's a lot on the medication, medical side, but there's also a lot on the lifestyle. What are you seeing that's maybe most ignored?
Well, the most ignored is actually diet. I mean, it's just the and it's tough. I mean, I'll be the first to admit I'm kind of embedded in this area here now. We're with these patients all the time. It's very difficult when you're in areas like underserved areas that diet is not addressed. Many of these patients, the education around what's going on. I can't tell you how many times, just some anecdotal stuff. I can't tell you how many times we've actually talked to patients who have no idea what type 2 diabetes is. They have diabetes and take this metformin or take this medication, and you're going to be on it forever. And truth be told, these providers and most providers, and we're talking internal medicine. I'm not talking endocrinologists. I'm talking, the front line, the family doctors or the providers. They don't have time to sit there and educate a patient on, the 30 minutes that it takes to talk about your diet. They talk about, our healthcare system is not set up that way. They don't get paid for that generally, and they don't get paid for that extra time. And so these patients, the lack of education around what they have is devastating. They don't have a direction. I guess that's probably what I'm trying to say is they don't have a direction. So they come in with this disease process and they don't know what causes it. They don't know how to get it better, and they haven't been educated. I mean that a lot of the education's out there, American Diabetic Association and so on, but they don't have access to that generally.
Unfortunate. So you're at a clinic today, obviously. Tell us what the daily interaction looks like with your population coming into the clinic in terms of treatment options, medications, injections. What your interaction look like daily?
Yeah, I mentioned a little bit earlier, the patients that come into the ED, the emergency room of the hospital here, generally what the statistics show, at least half of those, maybe a little bit more in a hospital this size, and most of the hospitals that we're talking about in Georgia, half of those patients are there because of hypertension, cardiovascular problems, and or high blood sugar, low blood sugar, diabetes, things like that. That's the main reason. So when these patients come into the clinic here or come into the hospital, they're generally referred directly to our clinic, and we do labs on them. If the labs haven't been done, we want to check A1C levels. We want to check vitamin B12, things like that are points that need to be checked in diabetes patients that we can improve on. So we check their A1C levels. The patient comes in on their infusion visits. Once we've done a complete workup, we do an exam and consultation. We do a diagnostic test, which is a neurovascular test. We want to check nerve flow and vascular flow to find out how their nerves and blood vessels have been affected by the diabetes over a period of time. So we have high levels, a high A1C level, 12, 13, their treatment is going to take longer than someone with, pre-diabetes or low A1C levels. But a patient, when they come in after the diagnostic workup at the consultation exam, and they actually sit in a Barca lounge, or I don't know if that's the right term, but it's actually like a lounge that you have in your living room, but they sit in that, it's comfortable. They're going to be hooked up to an IV and a pump, and in response to what their blood sugar levels are at the time that they come in, we check blood sugars every 15 to 20 minutes. We adjust the pump accordingly. So that pump actually puts a little burst of insulin into their bloodstream, and that insulin then goes out to the cells, and it is over a period of time. Again, over a period of time. This is not a miracle treatment that happens in 1 or 2 treatments. Depending on their A1C levels, it may take 8 weeks for them to really respond, or they may respond in 3 or 4 weeks. But for 2 hours, they get that little insulin burst back and forth, and their cells eventually respond. And then we get them rescheduled to come in. It's generally twice a week. Our care plans are generally twice a week for about a month, maybe 6 to 8 weeks, and then we readjust accordingly.
Let's back up. Obviously, they're in the clinic, they're receiving their treatment. Let's talk to those that we maybe want to try and keep out of the clinic, right? You've mentioned diet and exercise. What are some other small changes, if any, that those that are in the pre-diabetic, like you mentioned earlier?
Absolutely. Yeah, we get those patients. They come in. I'm glad you brought that up because that's huge. I mean, that's as important or more important than actually what we're doing. So we have patients who come in and they think they're diabetic, or their primary care provider has told them that they're diabetic, and maybe they're on metformin or some other medication. They come in and their A1C levels are below or in that pre-diabetic place. We don't treat them, but what we do, Jason, is we talk to them about, we do spend that time with them, even though it's not something that's a reimbursable. We want to spend that time with them to educate them on diet, on weight loss, on exercise, on if they're smokers, and many are stopping smoking, things like that. That's what we really want to focus on with those patients, because we want them to get well, and we don't want them to be patients of ours. We'd like to prevent them from going to that next phase of being full blown diabetic with that A1C level of over 6.5.
Great input. Appreciate that.
Yeah,
Just a couple more last questions from we've got some providers that are listening, obviously, just like where you're at, small rural hospitals. Speak to those for a second that, we're in a cost conscious environment. Obviously, margins are low, tough economic times, but you're a rural hospital listening to this, looking to, help serve the community in such a need. Help paint the picture of what they should look for, and that this is a good thing. You can financially thrive while also serving a health need in your community. What are some of the highlights you should pass on to them?
Yeah, I mean, you said it right there. I mean, all of these, the hospitals that you guys probably interact with, and most of the hospitals in rural Georgia, this is, using that term again, endemic to their local populations. I mean, they generally, not that they don't have answers, they don't have the time. They're seeing so many patients. So having a clinic such as this in that local area, not only relieves the burden on them, it helps their patient population. It's going to be good for the community. The response here in Millen, Georgia has been tremendous. I mean, we spoke at the Rotary Club the other day. We were invited to come in for that. It's just because there is such a need in the community. So what I would say to them is, this would be something to really check out. It would be something to learn more about. There's a lot of research on what we're doing. There's a lot of research on type 2 diabetics, and how this therapy actually helps them. Anecdotal. I mean, I want to bring this up. I just thought of it as we were talking about patients. We have a lady that she's been coming in for 5 weeks. Her presenting A1C level was 13.9. And we generally draw blood. We do the blood work, the labs. We don't always do it, but every 30 days or so. So her initial A1C about 5 weeks ago was 13.9. She came in 2 days ago, and we drew blood again, and it was down to 8.9. I mean, that's a tremendous. I mean, that's a, the doctors or the providers who are listening to this, that doesn't happen with medications, and so what we're doing is a long-term, for these patients, for these people, it's lifestyle change, but it's long-term. It's not something that's fly by night. It's long-term. It's gonna help them live a better quality of life, and help them, enjoy their kids, their grandkids, whatever it may be, and not be in the hospital every month because of hypertension and so on. So we're so happy that we're able to make that change.
Fantastic. Well, I got one last trick question for you. We're going to have this in our show notes, but I'm sure folks are going to have a lot more questions. How can they find you?
It's Dean R at diabetesnhc.com. MGT, so it's abbreviation for management, diabetesmgtclinic.com. That's Dean R, my first name, last initial, first initial, my last name, Dean R at diabetesmgtclinic.com. I mean, I'll give you my cell phone number. That's an easy way to do it. I'd love to talk to anybody who's out there that really has questions about this. My cell phone, my personal cell phone is 513-257-6499. And like I said, I'm just excited about what we're doing and where we're headed.
Fantastic. Great information conversation, Dean. We can talk for another hour, I'm sure. We'll have to do it again soon. And
Absolutely.
Really appreciate your time and joining us today. We know you're busy with patients, so we really appreciate it.
Thank you. Thanks, guys. I appreciate you inviting us on.
You got it. All right. Thanks, Dean.
All right. We'll see you guys. Thank you.
You've been listening to Beyond the Stethoscope, Vital Conversations with SHP, a production of Strategic Healthcare Partners.
For more information about our podcast, including back episodes, show notes, transcripts, and more, visit our website at shpllc.com/podcasts.
And I know you've heard it before, but please consider rating our podcast in your favorite podcast app. It helps make others aware of the show.
And our podcast wouldn't be possible without our wonderful team of folks.
Editing and production assistance by Nyla, Wiebe, and myself, Aaron Higgins.
And your episode hosts are Aaron Higgins and myself, Jason Crosby.
Our social media coordinator is Jeremy Miller.
Our executive producers are also our principals, Mike Scribner and John Crew.
For more from SHP, consider following us on social media, including Facebook, Twitter, and LinkedIn.
And as always, thank you for listening and have a great, wonderful day.
You already know that understanding your data is key to improving patient outcomes and financial performance. But how? At Strategic Healthcare Partners, our analytics services help turn your EMR and other data sources into actionable insights. From identifying areas for improvement to guiding you through implementing changes, SHP supports you every step of the way. Our performance analytics service dives even deeper, providing custom reports that help you stay ahead in the transition to value-based care. Unlock your data's full potential with SHP. Learn more at shpllc.com.